either the reason you were admitted to the hospital was not fully addressed, so you were not completely diagnosed, or you developed some additional infection or something else from the hospital. The point being that is there a way to use data to analyze the hospital admissions and to quantify the quality of the service provided by the hospital? And one of the ways that is being done right now is that in the US, for example, a hospital is penalized if there is a readmission of the hospital. And what a readmission means is that if a particular person was admitted into the hospital, say for pneumonia, that person gets discharged. If that person comes back to the hospital within a 30-day period for the same or a related reason, that is counted as a hospital readmission. So the reasoning out there is that when the person came in for the first admission, the disease was not diagnosed correctly enough, and the person had to leave the hospital, and it has resurfaced, and he's back. This hospital readmission, there are all this data that is being collected, and if a hospital is found guilty of these readmissions, they are penalized financially. So that is, in a way, the healthcare system's way of enforcing quality and better healthcare delivery into the hospital system. And there are multiple ways, again, to do modeling on the readmission. So you have all the data for people who have had, who have the same demography. A demography is your age group, your gender, where you live, what are your lifestyles. And if you have that population health data, and you combine that with your personal data and your disease that you have been admitted into the hospital for, and you update that on a regular basis to how you're reacting or how you're responding to treatments, you can have a pretty accurate model using data that will forecast whether you will be back in a 30-day time period in a hospital, and whether there will be a readmission. So a lot of hospitals now are using this predictive model. So what they do is that before they let go of a patient, they have this model score the patient on the probability of the patient coming back. Because at the end of the day, it's a trade-off. It's a trade-off between holding up a hospital bed for this same patient, which means that someone else who needs that bed is not able to access it, versus letting go of a patient too early and risking a readmission. So you always have a trade-off. So it's not a binary. And what these models do is that they have the continuous variable outcome, where they score, and it's almost like a risk score of a person being hospitalized again. Then we go into medication adherence, right? So if you're given, when a physician gives a prescription, one of the assumptions is that you're taking your medicines on a regular basis. And that is a big assumption, I know, for someone like me, right? I mean, if you are supposed to take a medication, say, after postprandial, so after dinner at 10 p.m. every day, you skip a few days, maybe you'll take it like just before going to bed, or maybe you take it like at 7 p.m. before you're going out, because you're going out for dinner. Now, do these things affect your diagnosis? Maybe, maybe not. But what is important is that if the physician has this data, the next time you visit the physician and the person looks at your chart and says, oh, you're still not responding to my medication. Are you taking it properly? That doubt, that parameter is completely made deterministic if this data is available to the physician. If the physician knows how often you're taking your medicines, if the physician knows what time period you're taking the medicines, then your subsequent diagnosis is a lot more effective than without all this data. Then, finally, once you go to the doctor, you get a medication, then you have your insurance bill come to your house, right? And that insurance bill, like when you signed up for it, when you decided that, okay, for every 100 rupees that is being charged, I will pay 40 rupees and the insurance will cover the rest. That science is a huge industry just by itself, and it's called the insurance pricing models. So what they do is that they try to determine, again, through your population health and with a combination of personalized risk models, they try to understand whether you as an individual are at a risk of getting hospitalized, whether you as an individual are at a risk of developing a chronic disease. See, for a healthcare system, one of the worst things that can happen is a chronic disease patient. Because a chronic disease patient, like a heart problem, diabetes, asthma, these diseases are very difficult to completely go away. And these diseases are something that you always are on medication, you have regular visits to the physician. So they are a constant cost center from that perspective for the whole system. So what is good for the system is to understand, who are the people who are at risk to develop this disease and pay special attention to those patients. So, for example, and the way to do that is, you can do something like a time series analysis. So if you have, for an individual, what are the different claims that the individual has done in terms of healthcare, right? Like how many times the individual visited a physician, what are the types of drugs prescriptions that were taken, was there any hospitalization? All this data is available to your insurance company because they are paying part of your bills. If that data can be fit into a model, into a predictive model, then there are a lot of models right now which can accurately forecast what will be your, what's your risk of hospitalization? What's your risk of visiting a physician more than 4 times over the next year? So for an insurance company, that becomes key to run, to generate their models on how to price the insurance. Because though they are providing a service, but at the end of the day, they are also trying to, keep people employed and to some extent, right, like run an organization. I talked a bit about it. There are different ways you can do it. You can have a logistic regression. You can have all these decision trees that access your health data and do a predictive modeling on where you will be in terms of your risk profile and your hospitalization and other things. The key thing out here is also, you want a feedback loop, right? As in every system. You have a data system, and this data system happens to be healthcare, right? You could have a data system like we saw the previous speaker, right? Like you have a retail system. The question is, it's okay to do a prediction, it's okay to understand what your consumers are saying, but where is my evaluation? Where is the feedback, right? Like if we do a forecasting model especially, every forecasting model, right? Like anyone can do a forecasting model. What separates the people are, how good are you forecasting in terms of your feedback. So the way it's done in the healthcare system is that you have different, you have this quality of care survey. So if you get hospitalized, what happens is that after you get released from the hospital, you get a survey sent to your home. And what that survey says is, it has different checkboxes. It has when you called for a nurse, was the nurse attending on time? When you asked for a certain thing, was the nurse rude? When the doctor came over, did the doctor adequately explain what your problems were? Right? So there are all these different dimensions in this survey. The other thing is that if you have the data of patients who are dissatisfied, who are going to register a complaint, if you have the data on the historical data of people who have done that, can you use a data analytics model, a predictive model, to understand who will do the complaining in the future? So in this slide, we look at what I talked about in terms of the quality. There is this whole model about Likert scale. So when you go into a restaurant or when you go into any place, right, like you have these questions that have a multiple scale response, right? Like it's either, did you like the place? Yes, no. Or how likely are you to recommend this restaurant? Very likely, somewhat likely, neutral, not likely, not at all likely, right? These are all what are called a Likert scale. So you can have a 5-point Likert scale, you can have a 3-point Likert scale. And if you get that data, what you can do is that using that data, you can do a factor analysis, you can do a principal component analysis to understand what parts of the healthcare system, what part of the hospital is working, and what part of the hospital is not working. So I'll give you a quick example, right? Like what was figured out is that on a particular floor in the hospital, they realized that there was a consistent low score being given to service for patients who were there for a particular evening in the week. And what then that boiled down to was that there was this one nurse who was primarily the responsible person for this low score. So if you can get such insights from your data, then what you can do is that you can have an actionable plan where you have a discussion with the nurse, and then that shifts your whole quality outcome. And that's the power of the data for the healthcare. Similarly, you can have a proactive connect with your patients if you know who are the ones who have called you, say either like the physician is not responding. These are calls that are coming into your call center. Oftentimes, insurance companies, healthcare, like hospitals, they run call centers. And those call center logs are very critical to understand what is working, what is not working. So that's descriptive. And also to determine a trend that can be used to forecast what might be the problem in the future. So in this particular model, for example, we did something where we were able to forecast the top 2.5% of the population, like who were going to complain, and we were able to adequately forecast that. It doesn't sound like a big number, but when you multiply that across, like say 60 million, that is a big, you get something that you can focus your resources on to try and connect with those patients. Visualizations, I thought this was interesting. This is something that was done by Florence Nightingale, where she tried to use visualization to effectively demonstrate, like in the army, like what were the cause of death for people who were coming in seeking medical help. So the point is, again, tying back to what I was trying to demonstrate with Aristotle, what we are trying to do today is nothing new. I mean, it is a big industry. It's generating a lot of buzz. But there have been efforts in the past. And if we look back, the way we are moving forward is because of the availability of all this additional data, the computers, and the cheap storage. So reporting forms, like what Florence Nightingale tried to do, right? Reporting forms a key part of understanding how your healthcare system is performing. It basically gives you an insight into the healthcare system. There are a lot of different ways you can do the visualization. You can also understand from the example of this nurse for a particular evening when she was on the floor, right? If you can get all this in a dashboard, your insights become a lot more clearer. And what happens is that, when you get a lot of these data, one is to have a prediction and a forecasting, right? That tells you that this is what can happen. But the power of data is actually to make a change, to be able to influence the health outcome. And that's what you can do through interventions. If I know, for example, that if dengue is now moving east, or it's moving to some other city in east of India, and I can have a pretty predictive, a good confidence around that, then what I can do is I can do an intervention. I can start fumigation, mosquito fumigations. I can be proactive about it. And that's what this whole area of interventions does. You understand, you understand how to effectively carry out an intervention. And once you capture the data for the intervention, you can also analyze your actions, your interventions by themselves. You can understand what intervention works, what intervention doesn't work, and answer the question why. See, in analytics, right, once you put causes, that gives you the why. Why what is happening is happening. Once you understand why, that's when you have the power to influence the outcome. Because now you know why is happening, how is more like the mechanics of the why, and then you can then tap into that understanding and you can influence your outcomes. So this is just a way to do the interventions if you're familiar with this methodology called design of experiments. So if I know, for example, it's almost like an A/B testing, in healthcare with a specific factor. So you can take a particular population, or say you take a particular geography, you take a particular region in the city, and then you apply some interventions on half of the region and you don't do for the other half. And you do the analysis based on your age, based on the gender, based on their, ethnicity is not that much, but risk stratification like we talked about. And your outcome is what intervention works, what does not, that effectively helps you to influence your health profiles. And the main two things that it's used for is this concept of disease management intervention, where if you have a pre-diabetic, for example, someone, like say, someone's parent is pre-diabetic, and you know that your parent has a disposition, then it would be great, instead of waiting for the onset of the disease, to have your parent in a disease management, case where you have regular nurse contacts, you're monitoring the profile, like how many times, what's the blood sugar, how many times has the blood sugar been checked, is there a fluctuation, and you try to manage that disease. And the other one is the lifestyle. So all of you know about Fitbit,